All right. Research to practice, breast cancer management in North Carolina. Updates for 2020 with Emily Ray, MD, Master's in Public Health. Dr. Ray is a medical oncologist with a clinical focus on the care of patients with breast cancer. Her research focuses on improving cancer care quality and understanding healthcare utilization among patients with advanced cancer. She graduated from the University of North Carolina at Chapel Hill School of Medicine in 2013. She then completed her residency in the internal medicine department at Duke University in 2016. She was trained as a hematology oncology fellow at UNC until 2019 when she joined the faculty at UNC. In addition to her clinical research, Dr. Ray is engaged in efforts to improve cancer care quality at the NC Cancer Hospital, and she serves as the Director of Wellness in the Division of Oncology. Dr. Ray, welcome. So glad to have you here today.
Well, thank you. Thank you for the opportunity.
Absolutely. And what's one more thing to round out your resume here that we should know about you in addition to so many of your technical qualifications or your healthcare expertise?
Well, I think in the COVID era when we're all doing more from home than ever, I'll mention that I'm here with my 13-year-old yellow lab. So you must be a dog lover to join the breast oncology group at UNC, and I am certainly that.
Great, great. Glad to hear it. So, well, let's take a look at our first question. Which of the following is not routinely evaluated in breast cancer? A, estrogen receptor ER status. B, progesterone receptor PR status. C, HER2 expression. Or D, BRAF mutations. So A, B, C, or D. And we'll ask our audience to go ahead and answer that poll. And while we're waiting for them to answer, I will say that this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and the CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. And Emily Ray, MD, MPH, has no financial relationships with commercial interests as defined by the ACCME. All right, Dr. Ray, let's give folks just a few more seconds to respond to that poll. We've got some different answers showing up, but it seems like people are really strongly favoring D, BRAF mutation. How are they doing?
That's exactly right. D is the correct answer. We routinely assess estrogen receptor status, progesterone receptor status, and HER2 expression, but do not routinely test for BRAF mutations.
All right. Thank you so much. And thank you to everyone for jumping right in and responding to that poll. Without further ado, breast cancer management in North Carolina, updates for 2020 with Emily Ray, MD, MPH.
Great. Thank you. Thank you again, everyone, for joining us today during what is certainly an unusual and busy time for everyone. Next slide, please. So by the end of this lecture, my goal is for you to be able to recognize the options for adjuvant therapy in early stage HER2 positive breast cancer, as well as describe the role of genomic assays in determining adjuvant treatment for early stage hormone receptor positive breast cancer, and being able to define the options for treating metastatic HER2 positive breast cancer. Next slide, please. So we'll get there by covering these focal points. I'd first like to review important updates in neoadjuvant and adjuvant therapy for early stage breast cancer, with a particular emphasis on chemotherapy de-escalation for HER2 positive disease, as well as the addition of immunotherapy in triple negative disease, and a discussion of the use of genomic assays in hormone receptor positive breast cancer. We'll also discuss the management of metastatic breast cancer with a focus on the role of locoregional therapy in this context, as well as really honing in on the therapeutic options in HER2 positive and triple negative breast cancers. And then briefly at the end, I think certainly it's timely and important to discuss the ways in which we've adjusted our approach to care during the COVID-19 pandemic. Next slide, please. So, of course, many of you know breast cancer remains the most commonly diagnosed female cancer and is the second most common cause of cancer death in women behind lung cancer. Next slide, please. And the North Carolina Department of Health and Human Services estimates that there will be more than 9,000 new cases of invasive breast cancer in our state in 2020. And you can see from this figure, which summarizes the national data, that while the number of new cases has been relatively stable over time, the deaths due to breast cancer have been steadily declining. And we think this is due to earlier detection with screening mammography, as well as improvements in therapies over time. And so the 5-year overall survival for breast cancer for all comers is nearly 90%. But despite many advances in early detection and an increasing range of therapeutic options, metastatic breast cancer remains incurable and is one of the leading causes of cancer-related mortality. Next slide, please. So I'd like to first focus on treatment of early-stage breast cancer, where improvements in treatment can reduce the risk of metastatic recurrence of breast cancer. And in the context of non-metastatic HER2-positive breast cancer, we standardly use a combination of chemotherapy and HER2-directed therapy. So typically docetaxel plus carboplatin plus trastuzumab plus or minus pertuzumab, depending on the particular clinical and pathologic features of the cancer. Next slide, please. And so you can see from this figure that there are an increasing number of HER2-directed therapies that are now available to our patients. This cartoon shows how many of these therapies work and how they interact with the HER2 receptor. On the left side of the figure, you can see trastuzumab, with which most of you are likely familiar. This is increasingly being combined with another monoclonal antibody, pertuzumab, especially in higher risk patients. There are also some small molecule kinase inhibitors that are available, so things like lapatinib, neratinib, and the newest player on the scene, tucatinib, which is used in the metastatic setting and we'll discuss here later. There's also, on the far right of this figure, you see an antibody-drug conjugate called TDM1 that we'll discuss. It's used in the clinical setting here in just a moment. But this drug relies on the monoclonal antibody, trastuzumab, to bind to HER2, but then smartly has a chemotherapy carrier on board that is brought intracellularly into cells that have HER2 expression, and allows that chemotherapy to be released once the drug is inside the cell. And so this is clever because it limits the exposure of the rest of the body to the chemotherapy. Next slide, please. And so in HER2-positive patients, we are increasingly taking a neoadjuvant or pre-surgical approach to chemotherapy plus HER2-directed therapy. This achieves several goals. We still aim to control micrometastatic disease with our systemic therapy the same way we would in the adjuvant setting. But taking the neoadjuvant approach may enable breast conservation in a patient who is otherwise not eligible at the time of presentation. It may downstage the axilla, enabling less aggressive surgical axillary approach. And important to the medical oncologist, it enables you to assess the tumor's response at the time of surgery. And then you can adapt the adjuvant HER2-directed therapy depending on the response. Next slide. And so let's take a look at this case. So you have a 56-year-old patient with an ER-negative, PR-negative, HER2-positive breast cancer. It's a clinical T2N1 who received neoadjuvant TCHP. And she has a good clinical response to therapy with a decrease in the size of the tumor on exam, as well as the mammogram that was repeated prior to surgery. She undergoes a lumpectomy and sentinel lymph node biopsy, and the final surgical path shows 11 millimeters of residual invasive disease, negative margins, 1 out of 4 sentinel lymph nodes with macrometastatic disease. Next slide, please. And so the question is, what would you use for adjuvant therapy? Would you use trastuzumab plus pertuzumab? Would you use trastuzumab alone to complete 1 year of HER2-directed therapy? Would you use TDM1 to complete 1 year of HER2-directed therapy? Or capecitabine for 6 months? And I'll give you a moment to answer. So it looks like our listeners are a little bit torn between our options here, with some choosing HP, some choosing trastuzumab alone, and then many choosing TDM1. The correct answer here, next slide, is C, TDM1. And the reason for this, so D is incorrect. There's no demonstrated role for adjuvant capecitabine in HER2-positive disease. C is a better option than A or B, and I'll explain to you why in the next slide. So please go ahead and advance. So we choose TDM1 on the basis of the Catherine trial, in which patients with residual disease, meaning they did not have a complete response to the neoadjuvant therapy and had some viable tumor present at the time of surgery, were randomized to receive TDM1 versus trastuzumab. And you can see from this figure that the use of TDM1 cut in half the risk of recurrence or death, with a hazard ratio of 0.5. And so based on these data, we adapt our adjuvant therapy in the HER2-positive space depending on the response to preoperative therapy. Next slide. So patients who had a pathologic complete response, meaning at the time of surgery there was no viable tumor, no invasive component of disease left, then it would be appropriate to continue the same HER2-directed therapy that was used in the neoadjuvant setting, trastuzumab plus or minus pertuzumab. But if a patient did not have a pathologic complete response after getting appropriate neoadjuvant therapy, then in the adjuvant setting we should switch to TDM1 based on the evidence from the Catherine trial that these patients who undergo this switch do better. And in doing so, this is contributing to improved outcomes in HER2-positive breast cancer patients. Next slide. So as we think about therapeutic choices for HER2-positive patients with early or locally advanced disease, some questions that we have are, does everyone need aggressive chemotherapy as the partner for the HER2 drugs? And are there perhaps some patients who don't need chemotherapy at all and would do well with HER2-directed therapy alone? Next slide. So to answer the first question, does everyone need aggressive chemo, the TC, part of the TCH or TCHP, or could some perhaps benefit from less aggressive chemo? And we learned from the APT trial, which is the adjuvant paclitaxel and trastuzumab trial by Sarah Tallaney and her colleagues, that there are some patients with small node-negative HER2-positive tumors that can do well with adjuvant paclitaxel and trastuzumab alone. Now, this was a phase 2 study, so there's no comparator arm, but they enrolled patients with tumors up to 3 centimeters, although you'll see in the paper that the overwhelming majority had tumors that were actually less than 2 centimeters in size. And patients underwent surgery first, which enables an axillary evaluation to ensure that they are truly node negative. And then they received adjuvant weekly paclitaxel plus trastuzumab for 12 weeks, followed by trastuzumab for an additional 9 months to complete the 12 months of HER2-directed therapy. And the primary endpoint in this study was disease-free survival. Next slide. So you see here on this Kaplan-Meier curve that the 7-year disease-free survival in this study was excellent, with 93.3% of patients being alive and disease-free, and only 23 recurrences out of 406 patients. Next slide. And so based on these findings in our practice for patients with HER2-positive tumors that are 2 centimeters or smaller and node negative, we treat with adjuvant paclitaxel and trastuzumab, sparing the patient the toxicity of the more aggressive TCHP regimen. Again, we don't typically do this for patients who have tumors that are clinically 2 to 3 centimeters or certainly 3 centimeters or larger, based on the underrepresentation of 2 to 3 centimeter tumors in this study. Next slide. And so that still leaves the question, are there some patients who don't need chemotherapy at all and would do well with HER2-directed therapy alone? Next slide. So there are several studies ongoing to try to answer this question. The ATOP trial is open at UNC and is a multi-center trial that is being led by our colleagues at Dana-Farber. And in order to participate, patients must be age 60 or older with HER2-positive breast cancer, and patients must either be ineligible according to the clinician's assessment or decline to receive chemotherapy plus HER2-directed therapy. So either the patient's not well enough and you don't think they tolerate the more aggressive approach, or the patient's preference is to take a less aggressive approach. These patients can and should still receive radiation and endocrine therapy when indicated, and the primary endpoint is disease-free survival. So in these patients, rather than receiving TCH or TCHP or even PH, some of the other regimens that we use combining chemotherapy plus HER2-directed therapy, they receive TDM1 alone in the adjuvant setting. And so if you have any patients who are reluctant to accept chemotherapy or you feel are not robust enough to receive it, we would be happy to see them and assess their eligibility for this trial. I think it's a great option, particularly for our older patients. And I suspect that in the near future, we'll have patients with early-stage HER2-positive breast cancers who will not need chemotherapy and only receive HER2-directed therapy. But we need further information through prospective trials like this one to try to determine in which patients chemotherapy can be safely omitted. Next slide, please. And so in triple-negative breast cancer, changing gears a little bit, similar to HER2-positive breast cancer, we are increasingly treating the majority of patients with neoadjuvant chemotherapy and then using the information from the surgical pathology to adapt our adjuvant treatment plan based on the pathologic response, the presence or absence of a pathologic complete response. So again, similar to the HER2-positive setting, this enables you to hopefully control micrometastatic disease, but also try to downstage the axilla, enable an easier surgery, and then assess response to therapy to allow adaptation in the adjuvant setting. Next slide. So let's look at another question here, another case. So you have a 48-year-old woman who received neoadjuvant dose-dense ACT for a clinical T2N0 triple-negative breast cancer. She undergoes a lumpectomy with sentinel lymph node biopsy, and the final path shows 15 millimeters of residual invasive disease with negative margins and negative sentinel lymph nodes. Next slide. So the question here is, what's your plan for adjuvant systemic therapy? Is the patient done? Option A, no further systemic therapy. Option B, capecitabine for 6 months. C, remember she already got dose-dense ACT, perhaps you could switch to TC for 4 cycles. Or D, pembrolizumab for 6 months. So thank you for your responses. Looks like the majority of you are appropriately selecting capecitabine for 6 months. And that's the correct answer. So There's a role for further systemic therapy using CAPE for 6 months. And if you'll advance to the next slide, I'll show you the basis of that treatment recommendation. I'm sorry, one more slide. Thank you. So this is the CREATE-X trial in which HER2-negative patients with residual disease at the time of surgery were randomized to receive adjuvant capecitabine for 6 months or standard therapy. Next slide. And so you can see from these Kaplan-Meier curves, looking at panels A and B on the top there, that all patients with HER2-negative disease seemed to benefit from adjuvant capecitabine. But it's important to note, looking at panels C and D, that the subgroup analysis showed that the improved outcomes in the entire study population were really being driven by patients with triple-negative disease, as seen in the lower panels. And in these patients, the risk of death was cut in half by use of adjuvant capecitabine, and these are the patients for whom we've adopted this approach. Next slide. And so for patients with triple-negative breast cancer who receive neoadjuvant chemotherapy and have residual disease, current standard of care is to treat with 6 months of adjuvant capecitabine. And it's important to note that the capecitabine can be started during or after adjuvant radiation. We typically at UNC start it after the radiation. Next slide. And so one of the wrong answers from the last poll question that may have caught your attention or tempted you was pembrolizumab. Another interesting question in triple-negative breast cancer is, given the known benefit of immunotherapy in the metastatic setting for these patients, does the addition of immunotherapy to neoadjuvant chemotherapy improve outcomes in earlier stage triple-negative breast cancer? Next slide. So this question is best addressed by the KEYNOTE-522 study, in which pembrolizumab versus placebo was added to neoadjuvant chemotherapy. So study participants had to have triple-negative breast cancer that was newly diagnosed, previously untreated and non-metastatic, and they again were randomized to either placebo with paclitaxel and carbo or pembrolizumab with paclitaxel and carboplatin. And then this was followed by either doxorubicin or epirubicin with cyclophosphamide with placebo or pembrolizumab. So basically patients got TC followed by AC plus or minus pembrolizumab. Next slide. So this visual abstract that the authors provide along with the New England Journal manuscript nicely summarizes the findings from KEYNOTE-522. You can see that the addition of pembrolizumab clearly improved rates of pathologic complete response with an absolute benefit of 13.6%. One limitation of this study is that the event-free survival data are still not mature. This publication reflects just the second interim analysis, but after 15 months of follow-up, we see a strong favorable trend for event-free survival, but it's important to note that it has not yet met the predefined boundaries of statistical significance for the study. So we would expect some updated analyses from this study probably in the next year or so, which I think will help more clearly assess whether the addition of pembrolizumab to neoadjuvant chemotherapy truly offers a survival benefit. Importantly, too, we see a slight increase in grade 3 adverse events for those who received pembrolizumab, and I think this warrants a closer look. And so let's go to the next slide and take a look at the adverse events table for this study. So I'd like to call your attention to the adverse events of interest, which are at the bottom of this table. These are the immune-related toxicities associated with the addition of pembrolizumab. And nearly 1 out of 5 patients receiving pembrolizumab experienced thyroid dysfunction, which is typically a permanent toxicity requiring lifelong medication use. Additionally, more than 2% of these patients developed adrenal insufficiency compared to none in the chemo plus placebo group. And while this is a small proportion of the total participants, this too is a lifelong complication which carries significant morbidity and risk of mortality. And so, again, this is just interim data, and so these adverse events are still preliminary. I suspect with longer follow-up, we'll see higher rates of immune-related adverse events as we've seen in other tumor types with exposure to immunotherapy. Next slide. So, getting back to the original question, does the addition of immunotherapy improve outcomes in early stage triple-negative breast cancer? So the bottom line is that we know that it improves pathologic complete response. We don't yet know if it improves event-free survival. And we know that there's a small but real risk of immune-related toxicity with potential real long-term implications for the patient. So this is the basis of a recent journal club conversation for our group at UNC, and we decided that most of us are not currently incorporating immunotherapy with neoadjuvant chemotherapy for our patients with triple-negative breast cancer, but it generated a lot of interesting discussion regarding the balance of benefits and harms and the use of interim analyses to inform treatment decision-making in the clinic. So the majority of us are still awaiting more mature data from this study regarding event-free survival to determine if the risks of adding pembrolizumab are justified by the benefits. But some in our group said they would use pembrolizumab in cases of very large tumors or extensive lymph node involvement in an attempt to clear the axilla and downstage axillary surgery in the hopes of benefiting the patient by allowing surgery with a lower risk of lymphedema and perhaps avoiding the need for adjuvant capecitabine. We're also awaiting the results of other chemo plus immunotherapy studies, including the NCI 10013 study, in which carboplatin and paclitaxel were combined with or without atezolizumab. So I think if immunotherapy is used in this context, it's paramount to make sure that patients understand there is some risk of lifelong immune-related complications and that we don't at this time have a clear survival benefit. And then they, along with their provider, can make an informed decision about treatment options. And certainly this is an area where we're all eager for updated information to help inform our decisions. Next slide. So we also have a clinical trial at UNC, the SWOG 1418 trial, which aims to help answer this question of whether adding immunotherapy improves outcomes in early stage breast cancer in a triple-negative setting. I like the study design because rather than giving immunotherapy to all the patients up front, as in Keynote 522, in this study, patients receive neoadjuvant chemo per current standard of care, and then are randomized only if they have residual disease of 1 centimeter or more or positive lymph nodes after chemotherapy. And they're randomized to either receive immunotherapy or just observation. And so it's kind of a similar mindset to the CREATE-X trial, which I just showed you, which means that only the patients who did not get a pathologic complete response after neoadjuvant chemotherapy go on to receive additional therapy. It is important to note on this study that patients can get adjuvant CAPE as per the current standard of care. So in that case, the sequence would be neoadjuvant chemo. If they have residual disease, then they would get adjuvant CAPE for 6 months, and then they can go on this trial. And the idea is that you don't expose all patients to the potential risk of immunotherapy, but instead only those patients who did not have an optimal response to standard neoadjuvant treatment. Next slide. So shifting our attention now to hormone receptor positive breast cancer, I'd like to discuss the role of genomic testing in treatment decision making and try to make sure everyone really understands the basis for using this approach. So in patients with hormone receptor positive breast cancers in the early stage setting, we recommend endocrine or anti-estrogen therapy for everyone. Next slide. And historically, really in the not so distant past, all patients with these tumor characteristics would have also received chemotherapy. But perhaps like the folks in the little icon there at the top left corner, oncologists were maybe a little too enthusiastic about the use of chemotherapy in this setting, and we now know that we were over-treating a lot of people. Next slide, please. And so we've since learned that there are some patients, in fact quite a number of patients, who do not benefit from adjuvant chemotherapy and can do well with endocrine therapy alone. So in hormone receptor positive breast cancers that are at least 0.5 centimeter or larger and are node negative, we use genomic assays to help us determine the recurrence risk with endocrine therapy alone and the potential benefit of the addition of adjuvant chemotherapy. Next slide. So what are these genomic tests really helping us understand? What are they providing? We know that there are these distinct clinical subsets of breast cancer according to receptor status, as shown here. And these clinical subsets remain important for determining which type of therapy to give those who need it. So is there a role for endocrine therapy? Is there a role for HER2-directed therapy? But they don't really tell us who will benefit, and they don't really tell us whether adjuvant chemotherapy should be given at all. Next slide. So through the work of Chuck Peru at UNC and many others across the world, we've begun to understand that there are multiple distinct molecular subtypes of breast cancer with varying gene expression profiles within each clinical subset. So this information can help us understand the expected recurrence risk and optimal treatment for a given tumor. So there are different genes that can be highly expressed or minimally expressed in different breast cancers, and based on these gene expression profiles, tumors can be categorized into different molecular subtypes. So for example, if you look at this figure on the far left, that's the luminal A molecular subtype. And if you look at the top row of the green and the red, you can see that the expression of estrogen receptor genes in this molecular subtype is high. That's why it's red for that row. And these tumors are generally responsive to endocrine therapy, whereas the luminal B subtypes, which are often also hormone receptor positive, have lower expression of those same estrogen receptor genes and are therefore much less likely to respond to endocrine therapy. Next slide. So you can see that even across patients who have estrogen receptor positive breast cancers would be in that same clinical subset shown in the Venn diagram, patients with luminal A cancers have a much better prognosis than patients with luminal B. And so we've begun to incorporate various genomic assays into our clinical context to help predict prognosis, and I'll tell you a little bit more about how we're using these in the clinic. Next slide. So Prosigna is a commercial version of this intrinsic subtyping and classifies tumors as low to high risk of distant recurrence, as seen in the top graph. So why give chemotherapy if a patient has a low risk based on their genomic testing? The test also predicts late relapse and can be useful in determining duration of endocrine therapy. That is, which patients are at high risk of relapse even after 5 years of endocrine therapy and therefore should be considered for an extended duration of endocrine therapy up to 10 years. Next slide. The Oncotype DX test is another genomic assay that can be used to predict recurrence risk and inform adjuvant treatment decisions. So it uses a 21-gene assay to develop a multi-gene expression signature according to the expression of 16 cancer-related genes and 5 reference genes, and then classifies patients into low, intermediate, or high prognostic risk groups. So notably, unlike Prosigna, Oncotype is not prognostic for late relapse. But we can use this test to guide adjuvant treatment decisions around the use of chemotherapy. So historically, all of the patients, even those in the low genomic risk group, would have received chemo. But again, why give chemotherapy if the patient is genetically low risk? And so with the availability of these assays, now we don't. Next slide. So these scores also are predictive of benefit of chemotherapy, with a higher genetic risk conferring higher chemotherapy benefit. Next slide. So, as many of you know, there are other assays on the market that can be used in this space. These are just examples of a couple. But it's important to note that we really wouldn't want to send one of these genomic assays in a patient who's adamantly opposed to chemotherapy or too frail to receive it. So these tests are really only helpful if the clinician and the patient are both considering chemotherapy and can help clarify if, in fact, that is appropriate. And so I'm not going to break down the TAILOR-X data today, but I would refer you to that study to look at the specific indications for how to integrate these genomic assays into your clinical decision making. But today just really wanted to make sure everyone understands the basis of that testing. Next slide. So what about the use of these assays in hormone receptor positive, node positive tumors? Next slide. This is an area where you probably see quite a bit of variability in practice. At UNC, we treat all patients with hormone receptor positive, node positive patients with adjuvant chemotherapy and do not use genomic assays in that context. The responder study, which involved endocrine therapy plus or minus chemo, is still ongoing, and I think that study will be really important to help us understand if, in fact, we can use these genomic assays in node-positive disease. But it's important to look to the evidence that we do currently have. So looking at the MIND-ACT study, this study showed that patients that had a high clinical risk, so for example, node-positive tumors, and low genetic risk or low risk on a genomic assay still benefit from chemotherapy. And this was especially true in premenopausal women. Some have hypothesized whether it's the chemo itself that's providing the benefit or perhaps the ovarian suppression caused by the chemotherapy. And then that leads to the question of, can you just optimize endocrine therapy and perhaps forego chemo in some of these node-positive patients? But I feel that we really need prospective, randomized, controlled trials to determine this. And so for now, as we await those trial results, we are treating all these patients with chemotherapy and do not order genomic assays. Next slide. So I'd like to again shift gears and talk about treatment for metastatic breast cancer, which importantly impacts about 40,000 patients per year in the United States. And while breast cancer deaths have decreased by about 40% over the past 25 years, there's still considerable room for improvement in outcomes related to metastatic breast cancer. Next slide. So the first thing that I'd like to discuss is a recent presentation from the ASCO annual meeting regarding locoregional treatment in metastatic breast cancer. Dr. Seema Khan from Northwestern presented these findings during the virtual scientific program plenary session. So patients who had stage 4 disease with intact primary tumor, meaning no prior surgery or radiation, were registered and treated with optimal systemic therapy based on the patient and tumor characteristics. And then those who did not progress during the first 4 to 8 months of optimal systemic therapy were randomized to undergo locoregional therapy for the intact primary tumor or no locoregional therapy. And the primary endpoint in this study was overall survival with locoregional disease control as the secondary endpoint. And what they found is that locoregional treatment of intact primary tumor does not improve overall survival or health-related quality of life. Next slide. And so to kind of cut to the chase here, there were 390 patients enrolled and received optimal systemic therapy, and then ended up only 256 of those were randomized to continue systemic therapy with or without locoregional treatment. Those who were not randomized were because they didn't meet that criterion of having response early on to their therapy. And what you can see is that there's no significant difference in 3-year overall survival, no difference in progression-free survival, and not unexpectedly, the locoregional recurrence and progression was higher in those who didn't get the locoregional therapy, but it actually didn't make a difference in terms of their quality of life. Favorably, it actually meant they had worse quality of life if they received the locoregional treatment. So the key take-home here is that there's no reason to intervene surgically or with radiation for the intact breast tumor in patients with metastatic breast cancer. Next slide. All right, so now we're getting to, I think, what is really the exciting area of breast oncology right now, looking at some of the updates in the treatment of HER2-positive metastatic breast cancer. So in this context, the first-line treatment with docetaxel, trastuzumab, and pertuzumab, and second-line treatment with T-DM1 are considered the current standard of care. Next slide. And in the third line, there's now an increasing number of therapeutic options with FDA approval, including tucatinib and trastuzumab deruxtecan. The clinical trials that led to approval of these drugs were presented in San Antonio in December of last year, and I want to walk you through their key findings. Next slide. So the HER2 CLIMB study enrolled patients with metastatic HER2-positive breast cancer who had previously been treated with trastuzumab, pertuzumab, and T-DM1, so at least third line. They had to have good performance status, and they were allowed on study if they had brain metastases, and you can see the requirements there for inclusion of those patients. And they were randomized 2-to-1 to tucatinib versus placebo plus trastuzumab and capecitabine. Next slide. And the primary endpoint was progression-free survival with secondary endpoints of overall survival, progression-free survival among patients with brain mets, and confirmed objective response rate and safety. Next slide. So the progression-free survival at 1 year, if you look at the Kaplan-Meier curve, find the 12-month mark and look at that dashed line, you can see it was 33.1% in the tucatinib combination group and only 12.3% in the placebo combination group for a hazard ratio of disease progression or death of 0.54. And the median duration of progression-free survival, if you look at the kind of top right of that figure, was 7.8 months in the tucatinib combination group versus 5.6 months in the placebo combination group. Next slide. And looking at overall survival, at 2 years, it was 44.9% in the tucatinib combination group versus 26.6%, again giving a hazard ratio of 0.66. And then top right of the figure, median overall survival was 21.9 months versus 17.4 months. Next slide. And because this study importantly included patients with brain metastases, we should look at this planned subgroup analysis. And you can see in this figure that among patients with brain mets, progression-free survival at 1 year, look at that dashed line, was 24.9% in the tucatinib combination group versus 0% in the placebo group. And the mean progression-free survival was 7.6 months versus 5.4 months. And so this highlights a key finding of this study, which is that even among patients with brain metastases, adding tucatinib to trastuzumab plus capecitabine resulted in better progression-free survival and overall survival than adding placebo. And common adverse events in the tucatinib group, as expected for a tyrosine kinase inhibitor, included diarrhea, hand-foot syndrome, nausea, fatigue, and vomiting. Next slide. So looking at the adverse events table, again, this is a tyrosine kinase inhibitor. The common ones were diarrhea, hand-foot syndrome, nausea, fatigue, vomiting, and diarrhea and elevated LFTs of grade 3 or higher were more common in the tucatinib group compared to placebo. Next slide. So I would highlight that tucatinib is a great third-line option for patients with metastatic HER2-positive breast cancer, especially in the presence of brain metastases where the results were quite impressive. Next slide. So the other drug to consider in the third line is trastuzumab deruxtecan, or Enhertu. These drugs are getting increasingly hard to pronounce. You have to sort of practice them in front of the mirror before you mention them to a patient. But this is an antibody-drug conjugate in which the monoclonal antibody trastuzumab, which we know and love, is linked to a topoisomerase 1 inhibitor. Next slide. So this was studied in the Destiny Breast 1 phase 2 trial, which led to its FDA approval. And because it was a phase 2 study, again, there's no comparator arm, so all participants received the drug. And they had to have been previously treated with TDM1. And the primary endpoint was overall response rate with secondary endpoints of disease control rate, clinical benefit rate, duration of response, PFS, and safety. Next slide. And so there are 184 patients in this study. Important to note, this was a heavily pretreated group. While patients could have been in their third line, having received TDM1 previously, the median number of prior treatments was 6. And so in the first part of this study, they established a recommended dose of 5.4 milligrams per kilogram. So all of these 184 patients received that recommended dose. And we see overall response rates of 60.9% with a median duration of follow-up of 11.1 months. Next slide. So this waterfall plot is a nice plot from the publication that helps you visualize the response rate. This reflects the change in baseline tumor size as a percentage. So again, to meet that overall response rate threshold, they had to have had a change of at least 30%. So you can see that 60% of patients fell into that category. Next slide. And then within the same figure, they break down the objective response rate in pre-specified subgroups with the vertical line here representing the median overall response rate. So a few key findings to point out here. One is that those who were not so heavily pretreated, who had received less than 3 lines of prior therapy, rather than up to 6 or more, as was their median, had a better response. And then those who were weakly HER2 positive, meaning they had an IHC of 1 or 2 plus with positive FISH, had lower response rates. So we know that HER2 positivity is on a continuum and can predict response to HER2-directed therapies. But still, even in these patients, the overall response rate was 50%. Next slide. Perhaps the most important thing to highlight about this study, the adverse events table, I'll just call your attention to the bottom, the interstitial lung disease, which earned this drug a special warning from the FDA in the package insert, that interstitial lung disease was seen in 13.6% of the patients, and there were 4 deaths on study related to interstitial lung disease. So certainly if you're using this therapy, it's really important to monitor closely for evidence or symptoms of interstitial lung disease, and if you suspect it, you should stop the drug immediately and treat the patient with steroids. Next slide. So I think the options for treatment of metastatic HER2-positive breast cancer are more promising than ever with these new drugs on the market. I would generally consider tucatinib in the third line, especially if a patient has brain mets, although trastuzumab deruxtecan certainly has some very impressive results from the studies we've seen so far in a heavily pretreated population. And there are some ongoing phase 2 trials that will help us better understand how this drug, the trastuzumab deruxtecan, can be used in clinical practice. Next slide. So I just want to give you a few updates about triple-negative metastatic breast cancer. And to make sure we're all on the same page about first-line therapy, I wanted to look at this poll question. Next slide. So this is a case with a 57-year-old woman with triple-negative breast cancer in 2018 who now has progressive dyspnea and is found to have multiple pulmonary nodules. She undergoes a biopsy and it confirms metastatic recurrence of her triple-negative breast cancer. Next slide. And so the PD-L1 on that metastatic site comes back as 1%. So what do you recommend for systemic therapy for this patient? Now I'll give you a moment there. Okay. So appropriately, you guys are selecting option C, nab-paclitaxel plus atezolizumab. Next slide. And next slide again. So this just, again, underscores that we need to assess PD-L1 on the metastatic tumor, and we treat with single-agent chemotherapy if PD-L1 negative, or atezolizumab plus nab-paclitaxel if PD-L1 positive, based on the Impassion 130 data, which I'm not going to review today, but can be found in the New England Journal as cited on the slide. Next slide. I know we're getting towards the end of our time, but I just want to briefly mention an option for third line called sacituzumab govitecan, which is now approved in the third line setting for metastatic breast cancer. Next slide. This is another antibody drug conjugate where you have a humanized antibody that binds to the cell surface of some solid tumors and then has a chemotherapy payload on board that's released intracellularly. This SN38 compound is much stronger than its parent compound, irinotecan. Let's go to the next slide, please. So this was granted accelerated approval by the FDA based on the results of a phase 2 study that was published in the New England Journal in February of 2019. And patients had to have metastatic triple-negative disease with at least 2 prior lines of therapy. Next slide. And important to note, there were 4 deaths during the treatment, although with metastatic triple-negative breast cancer, that may not be drug-related necessarily. But only 2.8% discontinued treatment due to adverse events, and the most common grade 3 or 4 adverse events were anemia and neutropenia. Next slide. So the response rate, or percentage of patients with at least a 30% change in their tumor, was 33%. Next slide. And the median duration of response was 7.7 months, with one patient, that top line there, and the swimmer's plot, having more than 36 months of response. And the median progression-free survival was 5.5 months, and overall survival was 13 months. Next slide. Actually, we can skip this one. Next slide. So sacituzumab is generally well tolerated. It's a good third-line option for patients, with the primary side effects being myelosuppression, which can relatively easily be managed with transfusion or growth factor support when needed. And of note and importance to our patients, it causes alopecia in only about 1/3 of patients. Next slide. So one area of investigation is whether the addition of immunotherapy to sacituzumab actually improves outcomes, and we have a study that we anticipate opening in the next year to try to look at this. Patients must be treatment naive, so first-line therapy, and the primary endpoint is progression-free survival. So keep this trial in mind if you have newly diagnosed patients with metastatic triple-negative breast cancer in the year ahead. So just lastly, as we wrap up, I wanted to highlight that COVID-19 has certainly impacted our approach to breast cancer care. We initially were using more neoadjuvant endocrine therapy in patients with hormone receptor positive tumors as a way to try to delay surgery when our operating rooms were initially closed. We've since backed away from that approach as our operating rooms are now back and fully open, but kind of keep that in our back pocket if beds become more limited in the months ahead as cases rise. We also initially were delaying the initiation of CDK4/6 inhibitors when we thought that this would be a short-term problem, trying to avoid the need for lab monitoring and the risk of neutropenia. Now that we know that this pandemic is going to last months, not weeks, we're really starting these drugs at the same time as endocrine therapy for our metastatic patients. And then we're relying a lot on telemedicine, particularly for patients that are not neoadjuvant and may not require such close exam monitoring. Patients that are new to our practice, we often do the first visit by video and get everything rolling and then see them in person for their next visit. Certainly second opinions, we're doing more and more by video visits, which in many ways has lessened the burden to patients by not having to travel to Chapel Hill if they don't live in the area. And we're using different platforms, but many of us have found that Doximity has been working well for us. So I welcome your input. I'd love to hear what others across the state are doing in response to this pandemic. And I really appreciate you joining us today and listening to my talk. I'd be happy to entertain any questions that you might have.
All right, Dr. Ray, thank you so much. This was extremely informative. We'll let our questions come in here, and we do already have one. In the face of BRCA positive, how do you factor in PARP inhibitors with MBC patients?
Yeah, so if a patient is BRCA positive and meets the qualifications for a PARP inhibitor, that certainly can be one of our options in that space. I think the timing of it or the sequencing of it with other therapies depends on several factors, including the burden of disease. So how many sites of involvement, do they have visceral involvement that needs to be rapidly controlled and perhaps might not be achieved with a PARP inhibitor up front. So certainly something to have in the sequence, but the exact timing really depends on the patient's characteristics, often not in the first line.
Dr. Ray, thank you so much. We'll take just a couple of more minutes to let any questions come in through Poll Everywhere. While we are waiting for those, I'm going to jump ahead and say our thank yous and get those out of the way. As always, we thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund. We thank the UNC Lineberger Comprehensive Cancer Center, and we thank Mary King, Veneranda Obore, and John Powell for all the work they do for each and every one of these lectures. As always, you can find us at unccn@unc.edu or 919-445-1000.